Welcome back to the new section on hyperglycemic emergencies. In the previous section, we have discussed in detail on the types of insulin and their clinical applications in practice. In this particular section, we are going to discuss on a very common disorder that you're going to encounter in your casualty or emergency practice and as a practitioner itself, that is hyperglycemic emergencies. And there are two hyperglycemic emergencies. One is the diabetic ketoacidosis called as DK in short, and second is the hyperosmolar hyperglycemic syndrome called as HHS in short. And as the name suggests, in DK, the major problem is going to be the ketoacidosis. Whereas in hyperosmolar hyperglycemic syndrome, the major problem is going to be the hyperosmolarity and not the ketoacidosis. So even though there are some subtle differences between these two disorders, but overall, they follow a common pathophysiology and they are going to have a common treatment, as I told you, but they have some subtle differences between them. It's important to understand these disorders because they are extremely common in your practice, and at the same time, the treatment of these disorders are going to be associated with more problems compared to that of the disorders themselves. So understanding the pathophysiology is very important to understand why we are giving a particular treatment when you are going to discuss about the treatment section. So before that, as I told you, we have to understand the pathophysiology better. So let us start with the pathophysiology of DK and HHS in the first place. So we're going to start with two hyperglycemic emergencies pathophysiology, that is DK and HHS, where DK is supposed to be due to insulin deficiency. That is a major problem as far as DK is concerned. But in HHS, there's going to be some insulin in the body. It's not in typical insulin deficiency. There is some insulin in the body, but there is not enough insulin and there could be insulin resistance. But there is some insulin that could actually prevent the lipolysis from happening and stop the ketoacidosis from happening. So that's why they don't have ketoacidosis in the first place. And because DK is due to insulin deficiency, we know very clearly it's very common in type 1 diabetes mellitus because type 1 diabetes mellitus is the one that is associated with an absolute insulin deficiency. So the most common presentation of a type 1 diabetes mellitus is DK only. So usually they present as DK. On the other hand, it can happen in certain patients. For example, 5% of the type 2 diabetes mellitus patients can also have DK in their life, but usually they do not present with DK. Whereas type 1 diabetes mellitus patients often present with DK, but as type 2 diabetes mellitus can have DK in their life, but they do not usually present with diabetic ketoacidosis. In fact, if they ask you in exam, what is the most common type of diabetes mellitus that presents DK, or what is the most common type of diabetes mellitus that often develops diabetic ketoacidosis or ketosis prone, your answer must be type 1 diabetes mellitus because that is the type of diabetes that is associated with a frank insulin deficiency. And because they have insulin deficiency, there's going to be many things that will happen in these patients. And the most important thing is the excessive counter-regulatory hormone. So which means it's not only the insulin deficiency that is going to be the problem, that's going to be relative excess in the counter-regulatory hormones. It could be relative excess or it could be even an absolute excess of these counter-regulatory hormones. We know what are these counter-regulatory hormones. They antagonize insulin, and the most important one is the glucagon as far as the beta cell axis is concerned. And we have other counter-regulatory hormones in the form of growth hormone. We have another counter-regulatory hormone in the form of cortisol. We have counter-regulatory hormones in the form of catecholamines. All are going to increase the blood glucose and they're going to antagonize the insulin action. We know insulin is an anabolic hormone, whereas the counter-regulatory hormones are basically catabolic hormones. And what are the reason for elevation of these counter-regulatory hormones in the first place? The first reason is insulin deficiency itself. So we know when there is a seesaw and one person has disappeared and the other person is the one who's going to entirely control the seesaw in the first place. When he's sitting, obviously seesaw will be down towards the gravity and the other end will be not having anything at all. So it's because of insulin deficiency itself, there will be a relative excessive state of this counter-regulatory hormones. And number two, the inciting event. So there will be always a precipitating factor most of the time with regards to the development of DK. So that inciting event itself can produce an excessive counter-regulatory response. For that matter, the most important reasons for development of this hyperglycemic emergencies are stressful events like infection or surgery. Even though DK can be triggered by discontinuing insulin or erratic doses of insulin, but most of the time it will be due to some stressful events like infection or surgery. So that inciting event itself can produce a stress response in the body, producing an excessive counter-regulatory hormones. And number 3 is due to the dehydration that is going to be the result of this disorder. So it's the result that itself producing a vicious cycle that is causing more counter-regulatory hormones and more problems, which means this disorder is going to result in dehydration. We'll be discussing in some time. And that dehydration and the resultant volume loss and hypovolemia itself will trigger the counter-regulatory hormones to rise in the body. So these are the 3 reasons why you're going to have excessive counter-regulatory hormones. But nevertheless, whatever may be the levels of the counter-regulatory hormones, the main problem is insulin deficiency in this setting. Because of the insulin deficiency, the liver cannot suppress gluconeogenesis, and because at the same time there are excess counter-regulatory hormones that stimulate gluconeogenesis, there's going to be accelerated gluconeogenesis in the liver. At the same time, insulin is essential to cause uptake of glucose in the skeletal muscle and adipose, which are the major utilizers of glucose in the body. So there will be reduced glucose uptake by the cells in the body, especially the skeletal muscle and the adipose tissue. So these things are going to result in significant hyperglycemia. These are the reasons why you develop hyperglycemia in this setting. But please understand the fact the gluconeogenesis that is activated is going to be the major reason for hyperglycemia compared to that of the reduced glucose uptake, which is only a minor component in the hyperglycemia that is happening in DKA. So this hyperglycemia is going to result in significant glycosuria, because we know the urinary threshold for glucose is 180 milligrams per deciliter in the blood. So if the blood glucose exceeds 180 milligrams per deciliter, the kidneys can no longer absorb glucose and they will be coming out in the urine as urinary glucose in the form of glycosuria. This is a diabetic or hyperglycemic glycosuria. Because you are having glycosuria, the urine osmolality will increase. Once the urine osmolality is increasing because of this solute excess in the urine, they are going to produce a form of diuresis called as solute diuresis. What do you mean by solute diuresis? This glucose that is coming out in the urine itself is going to pull out a lot of other things simultaneously. For example, they are going to pull out a lot of water, they are going to pull out a lot of sodium as well. So that is what we refer to as a solute diuresis. And at the same time, we know when once the water is pulled out of the cells into the urine from the kidneys, so you're going to draw potassium also in the form of something called as solvent drag. We have discussed that already. So you're going to lose potassium, you're going to lose sodium, you're going to lose water, even though the water loss is very high compared to the sodium, along with the glucose. And the result is going to be severe dehydration. And this severe dehydration is going to produce hypovolemia because of volume loss. And as I told you, hypovolemia is also one of the main reasons for this excess counter-regulatory hormones. And this excess counter-regulatory hormones, once again, they're going to produce more gluconeogenesis, more glucose in the blood, more glycosuria, and more dehydration, and subsequently more counter-regulatory hormones. So this is going to be a vicious cycle unless and until you stop this cycle by giving fluids and correct the dehydration, and by giving insulin, of course, which is very important in the setting of DKA. But dehydration in DKA is usually not associated with a frank shock. Very, very important point. And this is very true in children. And why you don't develop shock is the same reason of excessive counter-regulatory hormones, which actually prevent the shock in these patients. Suppose if the patient presents with DKA and shock, you have to be very careful in ruling out infection. That is sepsis causing septic shock. And number 2, patient might be having associated, because these are type 1 diabetes mellitus patients, the patient may be having associated adrenal insufficiency, which has to be ruled out for sure. And at the same time, patient might be having associated cerebral edema, which is a very, very important complication of DKA in children. Adults getting cerebral edema is very rare, even though they present with DKA. But children less than 20 years, especially less than 5 years, are very, very highly prone for cerebral edema. And DKA is a condition which is not only going to produce dehydration, they are also going to produce severe electrolyte depletion in the body. So it's not only volume depletion, it's also electrolyte depletion. The two most important electrolytes we know, potassium, which is the most important as far as DKA is concerned, along with sodium, which is also important. They can also have loss of phosphorus and magnesium, of which the phosphorus is going to be very, very important. So why phosphorus is important? Because resultant hypophosphatemia due to phosphate loss in the urine can result in rhabdomyolysis in childhood patients, especially in children. So that's why this becomes really important. And it's not only about high glucose and glycosylation dehydration, it's also about accelerated lipolysis that happens in DKA patients. And this is the most important reason for the DKA itself that is happening, that is the ketoacidosis part. So lipolysis acceleration is the most important component. So to understand this, we have discussed in detail about that. So let me tell in a short detail for those who are watching for the first time. So we have a very important catabolic hormone within the adipocyte called as hormone-sensitive lipase. We know this hormone-sensitive lipase is inactivated by insulin or inhibited by insulin, and it is activated by the counter-regulatory hormones like glucagon and catecholamines. Catecholamines are very important in this regards. Because in DK, there's going to be absolute or relative insulin deficiency and there's going to be excessive counter-regulatory hormones, the hormone-sensitive lipase is going to become really, really active, which is going to be converting the triglycerides that is present within the adipocytes to free fatty acids. So there's going to be excessive free fatty acids in the body. And the free fatty acids that are circulating in excess, they're going to be converted to ketone bodies in the liver. Normally, free fatty acids will be taken for triglyceride synthesis in the liver if there is sufficient amount of insulin. If there is no insulin, then the free fatty acids will be actually used to produce the ketone bodies in starvation states, which we know already. So acceleration of lipolysis is going to produce more free fatty acids. More free fatty acids will be taken by the liver to produce more ketone bodies. And what are the ketone bodies that are generated in patients with DKA or any fasting or starvation state? The most important is the beta hydroxybutyrate, which is going to be the most important ketone body compared to that of acetoacetate. And acetoacetate can spontaneously get converted to acetone, and this increase in acetoacetate, beta hydroxybutyrate and acetone is one of the quintessential factors that is happening in diabetic ketoacidosis patients. And this acetone is the one that gives the characteristic sweet smell or fruity odor in patients who are suffering from DKA. But if you ask what is the most important ketone body that is seen in DKA patients, that is beta hydroxybutyrate. Because beta hydroxybutyrate and acetoacetate are usually seen under normal circumstances at a ratio of 1:1. But in patients with diabetic ketoacidosis, the ratio can become as high as 10:1, which means beta hydroxybutyrate is going to be the most important. But unfortunately, our urine assays are able to pick up only acetoacetate and acetone. And whenever you are doing a urine test in DKA to pick up acetoacetate and acetone, you might get positive result, but it can grossly underestimate the background ketoacidosis because in DKA, there is lesser acetoacetate relatively in compared to that of the beta hydroxybutyrate. So testing the plasma beta hydroxybutyrate is going to be the most important as far as the treatment effect in DKA is concerned. And at the same time, to diagnose as well as for the treatment, the plasma beta hydroxybutyrate is going to be the most important. So this ketoacidosis, the ketone bodies producing acidosis, because these are acidotic compounds, so they result in acidosis also, is the main reason for certain problems that you're going to encounter in DKA in the clinical practice, like abdominal pain that the child and the adult experiences is due to the ketoacidosis, and the shortness of breath. In the sense, this is not a shortness of breath that is due to oxygenation problem, it is due to the acidosis. And because of the acidosis, to expel this excessive acid in the form of carbon dioxide, they're going to have a very deep and rapid breathing. That's called a deep labored breathing, called as Kussmaul's type of breathing or Kussmaul's respiration. That is due to the acidosis produced by these ketone bodies. And at the same time, as I told you, these patients can have a sweet odor or a fruity odor because of the acetone. But this is highly unreliable because the beta hydroxybutyrate is the most important ketone body as far as DKA is concerned. Now you will be understanding what really happens in DKA. It's due to absolute or relative insulin deficiency and simultaneous excessive counter-regulatory hormones causing excessive gluconeogenesis and accelerated lipolysis producing ketoacidosis. And please understand the fact that the ketoacidosis is going to be the most important component of a diabetic ketoacidosis, so as the name suggests. But on the other hand, hyperosmolar hyperglycemic syndrome, you do have some insulin, and this some amount of insulin is enough to suppress the lipolysis, which means lipolysis will not be happening. As I told you in the basic section itself, the amount of insulin that is required to suppress lipolysis is very, very less compared to the amount of insulin that is required to suppress the gluconeogenesis. So in HHS patients, you have some amount of insulin which is going to suppress lipolysis. In DK, you don't even have that some amount of insulin to produce suppression of lipolysis. That's why there is activation of lipolysis. In HHS, there will be some amount of insulin that can suppress the lipolysis. And at the same time, there's going to be activation of gluconeogenesis. And coupled with that, these patients will have insulin resistance that is going to be associated with reduced glucose uptake as well. As far as HHS is concerned, both are very, very important, because in HHS, majority of them will be type 2 diabetes mellitus patients, because having some insulin is not a feature of type 1 diabetes mellitus. It's always a feature of type 2 diabetes mellitus patients only. So that is the reason why HHS is a complication exclusive of a type 2 diabetes mellitus. And because these patients will have insulin resistance as well, there will be significant suppression of the glucose uptake by the muscle and the adipose. So this also forms a very important component for the hyperglycemia that you're going to see in patients with hyperosmolar hyperglycemic state. And we all know if there is no lipolysis, there's not going to be production of excessive free fatty acids. If that is not the case, then you're not going to result in ketone body production. At the same time, remember, in the presence of some insulin, the ketone body production in the liver also will be suppressed, even though if the free fatty acids are high, the ketone body production will be suppressed in the liver, because insulin is an anti-ketone body hormone. It's an anti-ketotic hormone. Clear? So the major problem in HHS is going to be the hyperglycemia. And it happens slowly over a period of time. Most often, DK is a very acute process happening within 24 to 48 hours, whereas HHS is a more subacute process happening over days to weeks. It cooks over some time. So the glucose starts increasing, and they produce serious glycosuria. And they're going to produce same problem, that is solute diuresis. And because of that, you're going to result in significant dehydration, volume loss and hypovolemia, and at the same time, you're going to result in significant electrolyte depletion as well. But please understand the fact, the amount of hyperglycemia that you encounter in patients with HHS is very, very high. Like for example, in DK, the usual serum glucose will be in the range of 250 to 400, somewhere around. But whereas in HHS patients, the glucose will be usually in the range of 800, 900. So it will be very high glucose. To get that high amount of glucose, it takes some period of time. So that is the reason why HHS is often subacute in nature rather than DK, which is acute in nature. And at the same time, this severe hyperglycemia is going to result in severe hyperosmolarity as well. So very high serum osmolality. That is a problem here. So this hyperosmolality itself can result in CNS complications and encephalopathy. So we know very well that if there is a cell, and outside if you are going to have very high osmolarity, that will result in cellular dehydration, which means the water is going to move out of the cell. So in the sense, there will be cellular dehydration, the cell will shrink, and that is the reason why these patients can result in CNS complications, because the cell that responds dramatically to these changes in osmolality is the neuron, brain cell. So that is the reason why they can usually present with encephalopathy. That's why previously it was also referred to as hyperosmolar non-ketotic coma, HONK coma. So that's the other name that was given for that. But anyways, we know now the problem is something very simple, that is severe hyperglycemia. That's the problem resulting in hyperosmolality. But you don't develop any ketoacidosis. So absolutely there is no ketoacidosis in these patients. It's only the hyperosmolality that is the problem in these patients. You can ask me one more question. Sir, you told hyperglycemia is there in patients who are suffering from DK also. Won't it raise the serum osmolality? Yes, it can also raise the serum osmolality, but the serum osmolality rise in DK is lesser compared to that of the HHS. That's why the major problem in HHS is hyperosmolality. That's why the name suggests hyperosmolar hyperglycemic state. So in patients with DK also, this hyperosmolality can result in encephalopathy, which means it's not like DK patients won't have encephalopathy. DK patients also can have encephalopathy, but the ketoacidosis is the prominent finding. Whereas in patients who are suffering from HHS, ketoacidosis is not at all a problem, and hyperosmolality is the most important problem resulting in encephalopathy. Clear? So compared to DK, HHS patients will not have ketoacidosis, will not have that Kussmaul's type of respiration, will not have that fruity odor, and will not have that abdominal pain. But they will be having more dehydration, more hyperglycemia, more glycosuria, and more electrolyte depletion. And at the same time, they'll be having more CNS complications as well. So this is the major difference between DK and hyperosmolar hyperglycemic state. And let's move on to discuss the problems in DK in a more scientific and understandable way. So we know the patients with DK as well as HHS are going to have dehydration. But let us restrict our understanding to DK first. So what is the level of dehydration that you expect in a DK patient? It's approximately to a tune of 5 to 10% is what the level of dehydration is in these patients. And one important point that you have to understand is the fact that clinically, the amount of dehydration in DK patients tends to get overestimated. So why you tend to overestimate clinically? That is because of the acidosis that these patients are having. Because of the acidosis these patients are having, the mucous membranes will be a little bit dry. Because of acidosis, they will be hyperventilating. And because of the same, because the constant movement of air in and out of the respiratory tract, the mucous membranes may appear a little bit drier than they really are. So that's the reason why it tends to get overestimated. So I can shrink the circle a little bit. Actually, the dehydration in DK tends to get overestimated than what it is really present. But it's the opposite in HHS patients. HHS patients tend to have more dehydration to a tune of 10 to 15% more than DK. We know that already, and they're going to have more electrolyte losses, which I have discussed already. But dehydration in HHS patients tends to get underestimated rather than overestimated because of the absence of acidosis. Clear? So patients with DK tend to have clinical overestimation of dehydration, whereas patients with HHS tend to have a clinical underestimation of their dehydration. So now we are restricting DK. Now let us move on to the sodium loss and the hyponatremia. But it's very important to understand the fact that this hyponatremia tends to get overestimated once again in patients with DK, diabetic ketoacidosis. So I can shrink the circle again. So dehydration tends to get dehydration as well as this hyponatremia tends to get overestimated in patients with diabetic ketoacidosis. Before understanding why it tends to get overestimated, we also have to answer the question why there is hyponatremia in DK patients or any hyperglycemic emergency for that matters. The first number one reason, the most important reason is hyperosmolar hyponatremia, which means the hyperosmolarity caused by huge glucose levels itself will result in hyponatremia. And this is also referred to as a false hyponatremia. There are two types of false hyponatremias. One is the pseudo hyponatremia and second one is the hyperosmolar hyponatremia. Both are false hyponatremias, the details of which I have told already in the sodium balance section itself. And the second reason for developing hyponatremia is the fact that these patients will have a sodium loss, actual sodium loss. So total body sodium itself is a bit low in these patients. And at the same time, these patients tend to have elevated ADH levels. This high ADH levels can be due to some underlying precipitating cause itself. I told you DK and HHS are often due to some precipitating cause like infection and surgery. So that itself can result in excessive ADH by a mechanism called SAADH, abnormal elevation of ADH. And at the same time, these patients will have physiological elevation of ADH due to the hypovolemic state that they are having. So this is a physiological excessive ADH. So because of both, there will be high ADH, and because of the same, there will be more hyponatremia than what you really expect in these patients. But most important reason for developing hyponatremia is hyperosmolar hyponatremia. So why you develop hyperosmolar hyponatremia? Let me describe in a very short way. So we know there is going to be some osmolar substance in the blood that is going to draw the fluid out of the ICF into the ECF. And in this condition, the osmolar substance is the excessive glucose that is going to rise the plasma osmolality. We know the fact that the serum osmolality is actually a measurement based on this formula called as 2 times the serum sodium plus blood urine nitrogen by 2.8 plus glucose by 18. So why we are giving the conversion factors? Because Indian standards have a unit of milligrams per deciliter. But if you are using in UK standards and European standards where the blood urine nitrogen glucose will be given in millimoles per liter, in that condition you do not have that conversion factors like 2.8 or 18. But we all also know that urea is not an effective osmol at all because it's freely movable inside and outside the cell. So it will not contribute to the effective serum osmolality. Only substances that are present only that are limited to the extracellular fluid only will contribute to the ECF or the serum osmolality. So now I can write 2 times the sodium plus glucose divided by 18. So under normal circumstances, glucose does not contribute to that much of serum or effective osmolality, but at abnormally high concentrations, the effective serum osmolality as well as the actual serum osmolality can rise, resulting in a hyperosmolar state. And this rise in the serum osmolality is actually caused by the glucose itself, right? It's going to be caused by glucose itself, and that is going to draw the water from the ICF into the ECF. And that is going to dilute the ECF and the intravascular compartment. So what's really going to happen is the intravascular compartment will be transiently loaded with water. That is because of the glucose causing hyperosmolarity, and we know water moves from a region of lower osmolality to a region of higher osmolality. And this causes a transient dilutional hyponatremia in the blood. So when you take the sample, it will show low sodium only because of the dilutional effect of water that is coming into the intravascular compartment, but transiently. Why it is transient? Because anyway, the glucose is going to be lost in the urine in the form of glycosuria. Once the renal threshold of 180 milligrams per deciliter is exceeded, you're going to result in glycosuria. And this is going to pull this water also outside, resulting not only in water loss, but other electrolytes also will be lost like sodium, potassium and phosphate. So this is the mechanism of decay that you're getting. So that is because of the water that is moving from inside the cell to outside the cell, causing a transient dilutional effect, causing hyponatremia. But what happens over time is the cell adapts to it. Because the cell is going to shrink, I have clearly shown in the image that the cell size has shrunken here because of the water movement outside. So the cell cannot keep on shrinking and losing water for a longer time. So it has to adapt by a principle called cellular adaptation. So because cell is a living structure and it has to adapt to the external environment, that's why it's living. So that is what we refer to as a milieu interior. So it has to make some changes within the intracellular fluid compartment so that it prevents further movement of water outside. So how can it do? You know very well, and the cell knows very well, that the water movement is happening because of the excessive osmolality in their environment. So the cell tries to generate that excessive osmolality and match with the osmolality that is present in the intravascular compartment, even though it cannot completely match, but still to an extent it attempts to match by generating excessive osmoles within the cell. So now this can effectively prevent the movement of water to an extent, and the cell can regain its shape. And this is what we refer to as cellular adaptation, very important mechanism behind the development of cerebral edema when you rapidly lower the serum osmolality. By treatment, when you rapidly lower the serum osmolality, you're going to result in shift of fluid from ECF to ICF, because the ICF will have relatively more osmolar force compared to ECF, because ECF you have drastically lowered the serum osmolality. So now the water movement into the cell will result in cerebral edema, and that is a very important complication of diabetic ketosis, which we'll be seeing subsequently. And what are these osmoles made of? These osmoles that the cell generates is usually a mya-inositol and taurine. So that's what the cell is going to generate. Very, very important point to counter the extracellular hyperosmolality. Now we know the mechanism behind development of this false hyponatremia, otherwise referred to as hyperosmolar hyponatremia. We also have to understand that there is a definite relationship between the rise in the blood glucose and the fall in the serum sodium. So how much sodium will fall for rise in glucose is what the question is. That is the basis behind the very important thing called corrected sodium equation. But this fall in the sodium can be taken as a little bit protective from physiological perspective, because this rise in glucose otherwise will result in serious increase in the osmolality. So the drop in the sodium is the one that is maintaining serum osmolality in an okay range and not allowing the serum osmolality to jump too much because of the rise in the glucose, which means to an extent it tends to be protective. Here the serum osmolality will be definitely high because of the excessive glucose, but the drop in the sodium in the blood is actually preventing too much rise in the serum osmolality because of the rise in the glucose. And to know the corrected serum sodium, you have to know a dictum. So before that, what is the dictum? For every 100 milligram per deciliter rise in the blood glucose beyond the normal value of 100, there is going to be the simultaneous drop in the serum sodium by 1.6 to 2.4 milliequivalents per liter. Clear? Because of the transient dilutional effect of moving water from the ICF to the ECF. So this is the relationship. So approximately I can take it as a value of 2 of serum sodium is going to drop for every 100 milligram per deciliter rise in blood glucose beyond a normal value of 100. So you can give it in the equation form. So corrected serum sodium will be equivalent to the serum sodium that is measured by the machine plus the blood glucose minus 100 divided by 100 multiplied by 2. So what is the idea behind this corrected sodium? So the corrected sodium will give you the sodium value that will be the sodium value if the patient's glucose was normal. That's the idea. So let us understand by an example. So suppose a patient's blood glucose is 600 and the patient's measured serum sodium is 128. We know that this is not a true hyponatremia, it's a false hyponatremia. It must be a false hyponatremia because the glucose value is very high here. So what will be the corrected sodium in this patient? That will be equal to the measured sodium that is 128 plus the blood glucose that is 600 minus 100 divided by 100 multiplied by 2. So it's 128 plus 600 minus 100 is 500 divided by 100 is 5 multiplied by 2 is 10. So the patient's corrected sodium is 138 milliequivalents per liter. So what is the concept behind this value of 138 in this patient? It tells you that if the glucose value is 100, that is a normal glucose, this must be the serum sodium. And the serum sodium is actually 128 because of the effect of glucose, nothing else. But once the glucose is corrected with insulin therapy and the patient's sodium will be this much only. Fine, all right. So what will be the Edelman equations prediction? And the correct equation is very, very important in giving fluid therapy. So once you are going to resuscitate the patient with fluid therapy, after that giving maintenance fluids, you need to check the corrected sodium. So let us understand that in some time. But before that, what will be the predicted sodium based on the Edelman equation? Edelman equation tells you the total exchangeable cation, that is total body sodium and potassium divided by total body water, will give you the serum sodium. We know that. But traditionally from the beginning, we have been studying this equation, that is total body sodium by total body water will give approximate amount of serum sodium. So we know in DKA patients, the total body water is going to be low for sure because of the osmotic diuresis. And at the same time, the total body sodium is definitely low, making the patient hypovolemic for sure. And the patient will be dehydrated. But again, the serum sodium will not predict the volume status. We know that already. It's total body sodium that's going to predict the volume status, which means definitely the patient will be hypovolemic in DK or HHS. No doubt about that. But the serum sodium is highly variable. Why? Because the serum sodium depends on how much sodium is lost. If the sodium loss is disproportionate, you will result in hyponatremia or hypernatremia. The sodium loss is proportionate, you will result in normonatremia. Suppose let us assume if the sodium loss is disproportionately lower compared to that of the total body water loss, you will result actually in a hypernatremic state. On the other hand, if the total body sodium loss is equal to that of the total body water loss, you will result in a normonatremic state. Or if the total body sodium loss is disproportionately higher compared to that of the total body water, you will result in a hyponatremic state, which means the patient can exhibit hypernatremia, hyponatremia or eunatremia according to the Edelman equation in a patient who is suffering from DK or HHS. But all these things you will not see clinically, and what you are going to see actually is the hyponatremia only. And the hyponatremia is due to only one reason, that is your high glucose. That's all. Clear? So actually the underlying condition can be either hypernatremia, eunatremia or even hyponatremia. But the patient's blood will always show, almost all the times, will show hyponatremia only. So that is the basis of fluid therapy. So a patient coming with DK and HHS will surely be dehydrated and severely hypovolemic at the time they come because they are lost a substantial amount of sodium in the urine along with water. So you have to resuscitate this patient first. Obviously, the total body sodium is low and the fluid of choice for resuscitation is going to be isotonic saline. So once you have resuscitated the patient and the patient volume status have now become normal, now obviously you will be starting with insulin infusion. So that is the basis of this flip therapy in hyperglycemic emergencies. FL stands for fluids, that is the first therapy, and I stands for insulin. Obviously, you'll start with insulin. I'll tell you more about that. And obviously, you need some potassium because of some problems which I'll be describing in some time. So first is always the fluids. After 30 minutes and 60 minutes of fluid resuscitation only, you are going to start with insulin. So now once the patient is volume replete, what fluid to give is a big question. Now whether to give a hypotonic fluid or an isotonic fluid, it depends on the corrected sodium. That's why the corrected sodium is very, very important. Suppose if the corrected sodium is low, that is less than 136, in that condition we know very well, low sodium can happen according to Edelman equation only if the sodium loss is disproportionately higher. So which means if the corrected sodium is low, the sodium loss is disproportionately higher and the patient is grossly hypolimic, in this setting you are going to continue maintenance with isotonic saline only. Suppose if the serum corrected sodium is normal or increased, which means giving subsequent insulin will definitely reduce the blood glucose and they are going to reduce the osmolar force exerted by the glucose. In that setting, the sodium is automatically going to rise, so you will actually end up in a hypernatremic state after lowering the blood glucose. So in that setting, you have to give 0.45% NaCl, that is half normal saline only. That is the fluid of choice. So your fluid choice will completely be dependent on the corrected sodium after the initial fluid resuscitation. Fine. Suppose you can tell in resource poor setting. Suppose if I am living in a resource poor setting, my sodium values will not be available that fast and quick. So in that setting, I can take arbitrary CBG cutoff of 250. Once the CBG goes below 250, I can assume that the corrected sodium would have become normal at that point and further lowering of blood glucose will result in hypernatremic state. So I will be starting with a half normal saline. So CBG value of 250 can be taken as a cutoff if you are living in a resource poor setting where serum sodium are not available immediately. But if your serum sodium values are available immediately, you have to use the corrected sodium measurements and then only you have to guide the maintenance fluid choice. But initial choice for resuscitation is always normal saline only. Clear? So that is why the corrected sodium is really, really, really important. And now let us move to the other electrolytes in the form of potassium loss. Please understand the fact that potassium loss in DK is substantial and especially in HHS is even more substantial and the actual potassium loss is much higher than the potassium loss that you are estimating. So usually in DK and HHS you tend to underestimate the potassium loss. You don't tend to overestimate, you tend to underestimate the potassium loss. Why? That is because the serum potassium is highly variable in a patient with DK and HHS. Especially in a patient with DK, the serum potassium is highly, highly variable. Why? So first, the patient will be having depleted total body potassium. In fact, the patient may have an entire total body potassium that is depleted, not entire total body potassium, entire ECF potassium that may be depleted in a patient with a DK or HHS. But they may have a normal serum potassium. How? First, let us understand what are the reasons behind this potassium loss. Reasons behind this potassium loss. Obviously, the reason number one is going to be the solvent drag. That is osmotic diuresis causing solvent drag, and that itself is going to produce a substantial amount of urinary potassium loss. Number two, this happens typically in DK only. That is because of the excess ketone bodies, beta-hydroxybutyrate and acetoacetate in the urine, which is nothing but anions. These are non-absorbable anions. I told you once the non-absorbable anions increase in the urine, they are going to create something called a apical membrane negativity because these are non-absorbable negative charges, anions. And the apical membrane or the luminal membrane of the distal nephron is going to become more negative. That's going to suck the potassium out of the principal cells, resulting in more urinary potassium loss causing hypokalemia. Not hypokalemia to be honest, but causing more potassium loss. There will be increased urinary potassium loss resulting in a gross loss of potassium from the patient, and in fact the patient would have lost entire ECF potassium in patients with DKA. But the serum potassium is highly variable. It can be normal, it can be increased, or it can be even decreased. So how is that possible? That is because of the other effects that are altering the serum potassium. Even though there is a continuous loss of potassium that is happening in the urine, there is a constant movement of potassium from the ICF to the ECF. So that will actually sometimes maintain the serum potassium, or even the serum potassium may be high depending on which is more. Either the urinary loss is more or the movement from the ICF to ECF is more. Depending on that, your blood potassium may be higher, normal, or even low. Obviously, we know the factors that are going to move the potassium from inside the cell to outside the cell. The number one being insulin deficiency without a doubt. Insulin is a very important hormone that's going to move the potassium from ECF to ICF through activation of sodium potassium ATPase. Insulin deficiency is a reverse scenario where potassium is going to flow from inside the cell to outside the cell. Number 2 is going to be the acidosis. Even though high N-gap metabolic acidosis and ketoacidosis is a very inefficient way to pull the potassium from inside the cell to outside the cell, still in the setting of insulin deficiency, acidosis becomes very prominent in their effect of pulling the potassium from inside the cell to ECF. Both these things are going to move the potassium from ICF to ECF. At the same time, you are losing potassium from the serum through urine. At the same time, you are gaining potassium from the ICF into the ECF, thereby rising the serum potassium. So it's a dynamic scenario where the loss and the gain is happening into the blood at the same time. So depending on which is predominant, you can have a normal, increased or even a decreased serum potassium. So that is the reason why whenever the patient is having a normal serum potassium in the setting of DKA, still I'll be taking it as a depleted state of total body potassium, because that normalization is just due to the movement of potassium from inside the cell to outside the cell. Otherwise, they are losing potassium. Or if the patient is having high serum potassium, which is a relatively rare scenario in a DKA, hyperkalemia, still it can happen, but I will assume there is some problem in the urinary excretion of potassium. That's why they're resulting in hyperkalemia. So in that setting, I'll check for the creatinine first. Or the patient may have a low serum potassium also. In this setting, it's considered to be really, really dangerous. There could be either too much loss in the urinary potassium, or in a realistic scenario, it tells you the fact that the movement of potassium out of the cell is insufficient to maintain the serum potassium, which means the total body potassium is so low, or intracellular potassium is so much depleted that the amount of potassium is not enough to compensate for the loss. So even though the serum potassium is just 3 milliequivalents per liter, so that will be considered as mild hypokalemia as per the classification, but in the setting of DKA, I will take it as a severe hypokalemia. So depleted serum potassium or low serum potassium in a patient with DKA indicates a very severe potassium loss, and that's an emergency. And giving insulin in that setting can result in dangerous arrhythmias and severe hypokalemia. So what will be the treatment implications? So once you start treatment with insulin, you're going to precipitate more potassium movement into the cell, resulting in more hypokalemia due to 2 reasons. One, insulin itself will cause more movement of potassium into the cell. At the same time, giving insulin will correct the ketoacidosis. Now, acidosis will be corrected. Once you correct the acidosis with insulin, that itself is going to produce more potassium entry into the cell, resulting in overt hypokalemia and severe hypokalemia, and the patient will go for arrhythmias and cardiac arrest. So that's why you have to be very clear in your dictum. Suppose if the serum potassium is high at the beginning, in this setting, I'll be giving just insulin. So in a hyperkalemic patient, there is no need to give potassium. So I just give insulin and wait for the repeat value of serum potassium, and later on I'll treat accordingly. If the patient's potassium is normal, in this setting, still it will be regarded as significant potassium loss in the urine. So in that setting, I'll be giving insulin along with potassium replacement. That's very important because giving insulin will anyway result in hypokalemia. So I have to replace that with potassium. The patient is having hypokalemia in a patient with DKA. This is a very dangerous scenario. Giving any sort of insulin is highly dangerous. So first replace with potassium in this setting. And once you made sure that the serum potassium is normalized, then you start with insulin and potassium infusion. So do not give insulin alone or insulin plus potassium if the patient is already hypokalemic. In a DKA, hypokalemia is a very dangerous sign. It indicates too much of total body potassium loss. So first give potassium, correct it, then start with insulin and potassium infusions. And there are some clinical pointers for diagnosing DKA and HHS. Clinical pointers are 4. First one is the polyuria, polydipsia and dehydration. So any child that is coming with polyuria, polydipsia and gross dehydration should be taken as DKA unless proved otherwise, and you have to check for the blood glucose and the ketone bodies in the blood and the urine. It can happen in HHS as well, the same polyuria, polydipsia and dehydration. In fact, it is more competitor of DKA. Another common thing between DKA and HHS clinically is the fact that they can come with unexplained encephalopathy. You have to evaluate for DKA. Any child with unexplained encephalopathy should be taken as DKA unless put otherwise, and you have to evaluate for that. And HHS can also come with encephalopathy for that matters in adults. And the patients with DKA can present with acute abdominal pain. As I told you before, this is due to ketoacidosis they have. And they can also present with tachypnea and shortness of breath. That is due to the acidosis once again. And often they have a very clear chest. Whenever they have a clear chest, you have multiple DDs. One of the important DDs is DKA because of the acidosis. So the first two, that is polyuria, polypside dehydration and unexplained encephalopathy, can happen in DK and HHS. In fact, the central nervous system problems like encephalopathy and dehydration is relatively more with HHS compared to that of DK. And your third and fourth point, abdominal pain and tachypnea, is a feature of DK only. You will not get that in HHS because this is due to ketoacidosis that these patients are having. Now let us see the differences between DK and HHS. The first difference is comparing the what type of diabetes that produces DK and HHS. Remember, type 1 diabetes mellitus very commonly produces DK. In fact, highest risk of developing diabetic ketoacidosis with type 1 diabetes mellitus only. In fact, type 1 diabetes mellitus children usually present with DK for the first time. For the first presentation itself will be DK most of the times. And who are DK prone? Type 1 diabetes mellitus patients. And incidence of DK is extremely high with type 1 diabetes. But the most common cause of DK in the world is not type 1, it is actually type 2. Even though less than 5% of the type 2 diabetes mellitus patients develop DK, only in the late stage they develop, but they never present usually with DK. Only in the late stage they are going to present with DK because of insulopenic stage. But because of the sheer number of type 2 diabetes mellitus cases we are seeing in the public, and the type 2 diabetes mellitus is grossly more prevalent compared to type 1, even though the incidence is less with type 2, but the most common cause of DK is actually type 2 diabetes mellitus patients only because of the total number of type 2 diabetes mellitus that is present in the community. Whereas HHS is usually a complication of type 2 only because there is some insulin here. So definitely some insulin present is not a feature of type 1 at all. So it must be a type 2 diabetes mellitus. And will there be any precipitating cause? There is no difference in that. Precipitating cause can be seen in both DK as well as HS, like infection and surgery. So that's not a difference. The next difference comes in the level of dehydration, where we know that HHS patients tend to be more dehydrated compared to DK. That's why I'm putting 2+. If you want to compare, DK patients tend to have approximately 6 liters of fluid loss, which is roughly equivalent to 5 to 10% of their fluids, whereas HHS patients tend to lose approximately 9 liters as an average, which is roughly equivalent to 10 to 15% of the total fluid in the body. And comparing the sodium loss, we know it's going to be more, and electrolyte loss as a whole is going to be more with HHS compared to DK, where the sodium loss is approximately 6 to 10 millimoles per kilogram in DK patients, whereas it is approximately 5 to 13 millimoles per kilogram in patients with HHS. It's slightly higher in HHS. And what about the potassium loss? Potassium loss, once again, is going to be a little more with HHS, whereas potassium loss in DK patients is going to be 3 to 5 millimoles per kilogram, whereas in HHS, it's approximately 4 to 6 millimoles per kilogram as an average. And there is going to be phosphate loss as well. Phosphate loss can be almost equal between them, where it is approximately 5 to 7 millimoles per kilogram, whereas in HHS, it's 3 to 7. I can write 5 to 7 millimoles per kilogram as well. It's almost equal. Even though phosphate loss is little similar, we know that phosphate less than 1 milligrams per deciliter is a very high risk for developing rhabdomyolysis in these patients, especially adult patients with HHS and children with DK less than 20 years, high risk of rhabdomyolysis, especially when they come for the first time. Rhabdomyolysis risk is a little higher with HHS, even though there is no significant difference in the phosphate loss in these patients, still a little higher with HHS compared to DK patients. And what about the abdominal pain in these individuals? Abdominal pain is a feature of DK, very unlikely to happen in HHS. And encephalopathy can happen in both, even though the risk of encephalopathy is more with HHS because of the hyperosmolality, which is more in HHS patients. And what about the fruity odor in the breath? That is a characteristic feature of DK, not a feature of HHS at all. What about hyperventilation, tachypnea and shortness of breath? Once again, characteristic feature of DK, not a feature of HHS. And if we see the serum glucose, now coming to the biochemical parameters, serum glucose more than 200 is sufficient to diagnose a DK, but according to the diagnostic criteria, but usually it will be in the range of 300 to 400. So that's the usual range of serum glucose in a DK. It usually does not exceed 500 because it's a very acute process. Patient comes very fast to the hospital. That's the reason. Whereas in HHS, it will be usually more than 600. To produce that much hyperosmolality, you need a very high glucose. That's why it comes subacute. It takes a long time to reach that 600, 700 level. But usually the glucose will be in the range of 800 to 900. Criteria wise, it's more than 600, but usually they will be presenting with a sugar of 800 to 900. And what about the plasma ketones? Remember, you have to do plasma ketones for safety, not urinary ketones. Plasma ketones will be either 3 plus or 4 plus if you do qualitative analysis, or you can also tell the beta hydroxybutyrate levels more than 3 millimoles per liter or 30 milligrams per deciliter according to the guidelines. So if it's more than 3, significant elevation of beta hydroxybutyrate is needed for development of diabetic ketoacidosis. Similarly, here there will be no ketones. They can be either negative or only trace positive. So usually by definition, the beta hydroxybutyrate should be less than 1.5 in a patient who is suffering from hyperosmolar hyperglycemic state. There should not be significant ketosis and there should not be significant acidosis as well to diagnose HHS. So which means I have to know the serum bicarbonate, which will be usually less than 15 in the setting of DK and more than 15, not much acidosis in the setting of HHS. And anion gap by definition usually will be more than 10 in the setting of DK because it's a high anion gap metabolic acidosis. By definition, HHS will have less than 10, normal anion gap, and there is no acidosis. And pH, arterial pH or venous pH. Usually we do in the venous blood itself because we don't want to puncture the arteries usually in a patient with a DKA. So in this setting, pH must be less than 7.3, confirms acidosis. It will be more than 7.3, telling it's not acidosis. So finally, we have the diagnostic criteria to tell whether it's a DK or HHS. To tell it's a DK, you need a triad. That is, you should have a hyperglycemia, that is more than 200 is enough, and there should be a ketosis defined as plasma beta hydroxybutyrate more than 3, and there should be acidosis defined as venous pH less than 3 or serum bicarbonate, venous bicarbonate less than 15. So that's why it is called a diabetic ketoacidosis. So just having hyperglycemia without any evidence of ketoacidosis, you cannot take it as a DK. That's a common mistake done by the practitioners. They think patient having 400 glucose, having a trace positive ketones means DK, admit the patient in ICU, start insulin infusion. That is absolutely wrong. You should not do that. You can treat that patient in the OPD itself. Even they have a glucose of 400, 450, it's okay, treat them in the home. They are not having ketoacidosis. They are compensated. So no need to admit the patient. You can just give insulin and ask them to take treatment from the home itself. As an OP basis, you can dispose the patient. Not a problem. No need to admit them. Ketoacidosis is what the problem that brings the patient to the hospital in this setting. So that's why you have to admit them. Clear? Similarly, how will you diagnose HHS? Again, you can put a triangle. Here the glucose level should be extremely high. That's a rule because without such a high glucose, you cannot develop HHS, hyperosmolality. So more than 600 by definition, it will be usually in the 800, 900. I've seen 1400 milligrams of glucose as well. And there should be no ketoacidosis. We know that because if there is ketoacidosis, it will go towards a decay only. So by definition, HHS should not have any ketoacidosis because there is some insulin that can stop the lipolysis and ketoacidosis from happening. So by definition, there should be no ketosis, means beta hydroxybutyrate should be less than 1.5 by definition, which means there is no significant ketosis, and the pH should be more than 7.3 and the patient's serum bicarbonate should be more than 15 by definition to diagnose it's a HHS. And number 3, patient should have hyperosmolarity. That's the defining feature of HHS, where the serum osmolality by definition should be more than 320 milliosmoles per kilogram. So, and having known about the differences between DK and HHS, we have to discuss about the DK in a slightly more detail because there are some classification systems also. So what are the 3 quintessential features of DK? We know the glucose more than 200 is enough to diagnose a DK because the most important feature of DK is not the hyperglycemia, it's the ketoacidosis. To tell it's diabetes, you need some hyperglycemia, and apart from that, you should have a ketoacidosis to diagnose it's a DK. Usually the glucose levels, as I told you, will be in the range of 300 to 400, not more than that. More than 500 is very unlikely to be a DK. Usually you don't get that much value in a DK patient. More than 200, but usually in the range of 300 to 400. Then the patients will have ketosis for sure. So, and we have to dissect this ketosis a little better. And how will you identify this ketosis is by doing either a urinary ketone test or a plasma ketone test. In general, plasma ketones measures the beta hydroxybutyrate beta-hydroxybutyrate, and the urine tests are going to use something called nitroprusside method, which is the same principle as that of the Rothras test, which we have discussed already. So it's going to use the nitroprusside dipsticks to detect the ketones. So which means nitroprusside test, already we saw that they're going to detect only acetoacetate and acetone. And here the important ketone is the acetoacetate, because acetone is not that important, because acetoacetate is the one that spontaneously get converted to acetone to an extent. So the acetoacetate is the more important. So nitroprusside tests that we use for the urine detection typically relies on the amount of acetoacetate and probably the acetone that is excreted in the urine. But we also know two facts, that beta-hydroxybutyrate is the major ketone that is excreted in the DKA. So beta-hydroxybutyrate is to acetoacetate ratio normally should be 1:1, but in DK patients it goes to a very high value of 10:1, which means the beta-hydroxybutyrate is the most important ketone body as far as DK is concerned. But by measuring acetoacetate, either we'll miss the early part of the ketosis or we might underestimate the ketosis. So that is one problem that's happening. And the second problem is giving an insulin therapy will push towards production of more acetoacetate, because they will convert the beta-hydroxybutyrate to acetoacetate, which means there can be persistent rise or even a paradoxical rise in acetoacetate in the urine, and the ketone bodies may look paradoxically elevated once you start the insulin treatment when you are doing a urine ketone. So these are the pitfalls. All the pitfalls I have told you already. So what are the pitfalls? Pitfall number one is the point that they have a delayed rise, because in the early part only beta-hydroxybutyrate will rise and acetoacetate may not rise. So you might miss very early ketosis and ketoacidosis. Number two, you are going to grossly underestimate the magnitude of ketoacidosis that is happening, because you are measuring acetoacetate, which is only 1/10 in comparison to the beta-hydroxybutyrate. So you are going to underestimate the magnitude of background ketoacidosis. Number three, there could be persistent rise of acetoacetate and positive ketone bodies in the urine despite treatment. Despite starting treatment with insulin therapy, there could be a percent rise. In fact, sometimes even after starting insulin, there could be a paradoxical rise in the urinary ketone. So it cannot be used as a marker of treatment. Cannot be used as a marker of treatment. Clear treatment efficacy. So that is the reason why currently we all prefer doing a plasma beta-hydroxybutyrate, which is more reliable in this setting. A very high plasma beta-hydroxybutyrate is again unreliable, but overall compared to the urinary ketones, these plasma ketones are highly reliable in the setting of a DK. So what are the various values that you have to know? So normal beta-hydroxybutyrate in the plasma should be less than 0.3 to 0.6 millimoles per liter. And in the setting of overt ketosis, like DKA, the values will be more than 3 millimoles per liter. That's the diagnostic cutoff. In the setting of resolution, so if you want to tell that the ketosis has resolved, which means a very important ketose condition is DK. So if you want to tell there is a resolution of DK, the beta-hydroxybutyrate should come to less than 1 millimoles per liter. For HHS, the cutoff is different. It is less than 1.5 millimoles per liter. So these are the numbers that you have to know with regards to beta-hydroxybutyrate levels. At the same time, there will be some textbooks which will give the values in milligrams per deciliter, which gives you too much of confusion. But you know already the values in millimoles per liter. Suppose if you want to convert the millimoles per liter to milligrams per deciliter, the conversion factor is very simple. You have to divide by 0.096. This 0.096 is the conversion factor here. Similarly, if you want to know the millimoles per liter value and you know the milligrams per deciliter, so take the milligrams per deciliter value and multiply by 0.096. So that is the conversion factor here, to convert milligrams per deciliter to millimoles per liter or vice versa. But our understanding clearly tells you can approximate this to 0.1, right? So we are medico, so we are there to approximate. So you can approximate to 0.1 approximately, even though it's not very correct, but still for our understanding, we can do that for exams. So here I can write less than 3 milligrams per deciliter. Here I can write more than 30 milligrams per deciliter. Here I can write less than 10 milligrams per deciliter, and here I can write less than 15 milligrams per deciliter approximately. These are the converted values to milligrams per deciliter. And I can even tell the severity of decay based on the pH and bicarbonate values. So based on pH and bicarbonate values, serum bicarbonate values, venous bicarbonate values, I can tell the severity. So if the pH is in the range of 7.2 to 7.3, and if the bicarbonate is in the range of 10 to 15, I can call it as a mild decay. If the pH is in the range of 7.1 to 7.2 and bicarbonate is in the range of 5 to 10, I can call it as a moderate decay. And if the pH is less than 7.1 and if the bicarbonate is less than 5, I can tell it as a severe decay. Remember, this classification is very important because this will guide the fluid therapy also, which we'll be discussing subsequently. So this is the BPSCD guidelines for severity of decay. And similarly, you have certain Western guidelines that tells you based on the pH and bicarbonate, if the pH is 7.2 to 7.3 and bicarbonate of 15 to 18, it is called a mild decay, and if the pH is 7 to 7.2 and bicarbonate of 10 to 15, it's a moderate decay, and if it's less than 7 and bicarbonate of less than 10, it's a severe decay. But I strongly urge you to follow the BPSCD guidelines. So this is more accurate compared to the Western guidelines, to be honest. And how will you treat a mild decay? Mild decay patients can be treated at the ER as a short observation and they can be disposed safely most of the times, unless and until they have some other reason like severe sepsis that is warranting admission. Moderate decay patients definitely need IP admission, and you can escalate them to ICU in times of need. Severe decay patients obviously has to be managed in a ICU only, ICU setting only. There is no doubt about that. You have to manage in the ICU setting. And at the same time, we also have to know what is not decay. That's also important. So suppose there could be certain situations where there will be only ketosis and acidosis. So third part we have not completed. So let me write acidosis here, which is defined as a pH of less than 7.3. That's the most important. And bicarbonate, yes, less than 15 is important. But in my setting, I'll be using a pH more than the bicarbonate. So there could be a scenario where you might be having only ketosis and acidosis without any evidence of hyperglycemia itself. So what I have done here is I have just told that these patients are having only ketosis and acidosis without any evidence of hyperglycemia. So this is what we refer to as a euglycemic ketoacidosis. Euglycemic ketoacidosis can happen in the setting of pregnancy, can happen in the setting of SGLT2 inhibitors, which we'll be discussing subsequently in the type 2 diabetes mellitus chapter. And it can happen in the setting of recurrent vomiting like hyperemesis gravidarum possible, and it can happen in the setting of organic acidemia. Like there are many inborn errors of metabolism that results in organic acidemia. So you have to think about that as well. So usually in children, you think about organic acidemia. In adults, you think about pregnancy, SGLT2 inhibitors and recurrent vomiting. So this is point number 1. And number 2, there could be certain scenarios where the patients will be having only hyperglycemia and ketosis. So they will be having only hyperglycemia and ketosis. So hyperglycemia and ketosis, which means there is no acidosis. So this cannot be taken as a decay. So they are having only hyperglycemia and ketosis. So this is usually the case if the patient who is having a type 1 diabetes mellitus not resolving adequate insulin, not receiving adequate insulin therapy. So these patients need not get admitted once again. It's just because of the mild insulin deficiency that they are having. Because of inadequate insulin, you are seeing this picture. So you can manage as an OPD based itself. Just you have to increase the insulin in this condition. Apart from that, you don't need anything else. So no need to admit these patients, and these patients are not diabetic ketoacidosis. And finally, you have a condition where you might be having acidosis and hyperglycemia, but there is no ketosis. And again, this cannot be taken as a ketoacidosis in the first place. So these patients are having only acidosis and hyperglycemia, and this cannot be taken as a DKA. Please understand the fact that this is very common in the setting of a stress hyperglycemia. Very commonly, you will encounter this in the ICU settings. It's a stress hyperglycemia. Patient may have acidosis because of the background hypoxia, and patient will have hyperglycemia also. That's because of the counter-regulatory hormones, but there will be no ketosis because there is enough insulin to prevent the ketosis in their body. So this often you will encounter in the stressful states like in ICU. So you have to know what is DKA, what is not DKA, and how to treat DKA and how to classify the DKA severity. So high glucose with ketosis and acidosis is DKA. Only ketoacidosis with normal glucose, still you have to think about euglycemic ketoacidosis. High glucose with ketosis alone, think about type 1 diabetes mellitus patient receiving inadequate insulin. So just increase the insulin as an OP basis itself, no need to admit them. And having high glucose and acidosis but no ketosis usually happens in the setting of a stress hyperglycemia. That's all. So final take-home point is the fact that just because the urinary ketones are positive, just because the patient is having ketosis, do not admit the patient unless and until you analyze the patient properly and diagnose a DKA in that patient. That's the take-home point. So let us stop with this, and in the next section we are going to discuss on the management of this hyperosmolar conditions in detail.